Okay, welcome everyone to our second personalised care podcast. In the first one, which was goodness me, a couple of months ago now, we explored effective supervision in social prescribing. We made a commitment. I know there's been a bit of a gap, but we did make a commitment to carry on doing videos or podcasts rather, exploring the things that people were telling us in the system were really, really important to them, and that they felt that we needed to explore more, especially if they were quite contentious or created was subjective, or actually people just wanted a little bit more help and understanding about how to unpick certain things that needed unpicking. In today's podcast, I'll let him introduce himself, but with Nathan Thomas from Black Control CV. Nathan, do you want to introduce yourself?
Sure, yeah. So my name's Nathan. I work in the primary care team at the Black Country Integrated Care Board, and I'm a data analyst by background. I work mostly that experience has been with workforce data, but also branching out into other kinds of data as well.
Lovely. Thank you, Nathan. So you'll get to know more about Nathan when he articulates some of the responses and the things that I'm going to throw at him now about his angle. And I suppose as well, it's probably quite important to explain a bit of context to our audience about how me and Nathan met. So we work for the same organisation. Um, We were at a personalised care conference, I think it was in October, weren't we? And there was a presentation made similar to the content that we're going to talk to, but it got us having a conversation about a previous conference that we'd been to around social prescribing for children and young people, which I think you presented at that, didn't you, Nathan? Was it in Wolverhampton? Yeah, yeah.
Yeah.
I haven't got dementia yet. My memory hasn't lost me. Um, and that was where I think we found out that we had some common interests around impact measurement generally in personalised care and the kind of little nuances and problems that people encounter about that.
Yeah.
I think I shared a paper with you that I read about 4 years ago that had been written as a kind of nudge, a bit of a moan, I think, but it hadn't really gotten anywhere because of different circumstances. And then yeah, one thing led to another, and then we've had a few conversations. We thought, wouldn't it be nice if we just try and draw that together, maybe in a podcast? So, and here we are today. A few months later, then yeah, but we moved. We're making it happen. We're making it happen. Okay, so what we're going to do, we'll try it. I mean, it's normally pretty informal. We'll try and do it. It's in three sections. We'll probably go for a bit of context about what we mean by supported self-management. Then we'll dive into what are the challenges around measuring impact in supported self-management, and then the final bit will be about, okay, well, what do we do next? What are some kind of useful nuggets for people to either influence to carry on this conversation, so it informs really good commissioning, or in whatever role that people are working on, whether or not they are already working in a role around supported self-management, and they just feel like they just want to increase their, I don't know, the recognition, for example. They might be coming from a different angle, but there'll be some useful nuggets at the end that will, I suppose, it's a call out for people to carry on having the conversation, to try and, I suppose, get to a place where we become more progressive in how we look at supported self-management and how we evaluate it, whether it's a success or a failure. Um, so I'll pause for a minute. Nathan, what's your understanding? I mean, I know there are different descriptions of it, so we can probably spend a bit of time. What's your understanding of what we mean by supported self-management? I suppose that's the first question.
It's a really good one. I think the analogy that I like the most, and this is perhaps more applicable to health and well-being coaching, which is a part of self-supported management that I have done the most work with, but it might resonate with other professionals working in this space as well. Like I kind of think about it as like running a marathon. So I've never actually run a marathon, but I've watched other people do it, so that makes me an expert. Um, and my understanding of it is that, you know, when you're running a marathon, you've got all these things to think about, like what's your pacing strategy, um, when are you going to eat and drink, how are you going to maintain good running form, um, and I like to think of all those things about as being equivalent to those things that we do that keep us healthy, right? So eating a good diet, getting enough sleep, physical exercise, and all that kind of thing.
Yeah.
And when I think about supported self-management, uh, in terms of this kind of like marathon analogy, um, that's about getting to the start line, right? So it's about, you know, what you need as an individual to make sure you show up at the start for ready to run your marathon, right?
Yeah.
Um, and how can we as a system, as individual practitioners, support individuals to show up, right?
Yeah.
Because if people aren't able to even get to that start line, for whatever reason that might be, um, then how can we expect them to run this marathon of keeping themselves healthy?
Yeah.
Um, so that's the way I kind of think of it. It might not be the only way or the right way or whatever, but
No,
that's what
I
I have
like
in
that
mind.
analogy. I like that. I suppose um continuing on the form, for want of a better word, pardon the pun, form and marathons. I've never run a marathon, by the way. Crikey, I have to give it a shot one day. I suppose continuing that vein, how I imagine it is that if that moment where they get to the water station and they've got that little bit of time to talk to someone, like their
Mhm.
trainer or whoever it is who gives them that bottle, that's that tiny amount of time. And I suppose the comparison in supported self-management is that if you were having like long-term treatment for your diabetes, you'd see a healthcare professional for tiny pieces of time, and then you're
Mhm.
just left to go out in the world, aren't you, and run your race at your pace.
Mhm.
In the grand scheme of things, really, there's very little amount, but very impactful amount that a health and social care professional plays. They literally see people for very short bursts of time, which is why a lot of the knowledge, skills, and confidence is really down to that person. I'm not. I mean, heaven forbid, I don't want people to go away from this podcast thinking Tez is saying that healthcare professionals do nothing at all to transform the lives. That's not what I'm saying. That's not what I'm saying. But what they do is create some conditions for some transformation to happen through like coaching conversations or facilitating peer support groups, or it could be very structured education that is doesn't involve as many people, but whereas the patient's literally just consuming the things and just developing their own self, their own levels of confidence. But yeah, that's a similar analogy that how I think of it. Um, but yeah, but there probably are loads of other different, and it's normally associated with coaching. I would suppose is the kind of the bread and butter thing. Social prescribing again is regarded as some kind of social as supported self management, peer support, another one. So yeah, lots of different definitions for it. Um, I suppose moving on to then, why do you think evidencing impact of supported self management? Why is it really, really important, and especially in respect of commissioning, but also in respect of things like population health management generally? Why is it so important?
I think there's a couple of things there. I mean, obviously, when you are a commissioner in the public sector, you are you have responsibility for taxpayers' money, and you want to make sure that you're spending that in a responsible way. Same thing, if you're a charity that makes grants, then you've been entrusted with somebody else's money, and you've got a responsibility to make sure that you're spending that money in the best way possible. Um, but I think the second reason why we might be interested in measuring impact, and evaluating supportive self-management, um, is that we also have a lot to learn about how to do that well. It's not to say that there aren't people out there doing it well, but we the, the there are so many different ways in which we can approach this problem. Um, and there are so many different needs out there that need to be met. People living in different circumstances who, respond better to different types of intervention. Um, and for in terms of effectiveness, we also want to understand what works and what doesn't, and for whom,
Yeah,
so uh, we can make a difference to as many people as possible.
yeah. Okay. I mean, we're talking from an individual level, aren't we? Obviously, individual outcomes, but from a population health management perspective, it's that but even bigger than that. It's that challenge of thinking, right, okay, how can we even think about? I think I think the paper I wrote a few years back now. I'm trying to remember now, but one of the things that did come out of it was that in the same way that we kind of segment our population and look at key themes that explain their propensity to behave in a certain way in terms of them accessing something or not, as the case may be, or having a level of outcomes where you can look at it and go, right, okay, this group has that level of outcomes, and we can explain they have those outcomes compared to that group not having those outcomes for a number of reasons. I think what the paper I wrote about kind of was challenging to say, right, okay, how from a population health perspective, where does knowledge, skills, and confidence come into that? And is it even possible to start segmenting that to say, right, patients with this level of confidence have a propensity to be quite successful for these interventions, whereas ones with a lower level of confidence might did.
Yeah,
And that's, I think, what's probably fueled the conversations that we've had in the office and at
yeah,
conferences and stuff.
yeah. And
Okay.
that's certainly one of the things that we've looked at through our framework for measuring the impact of health and wellbeing coaches, because we identified that as part of our model for how health and wellbeing coaching works,
Yeah.
and what the influences are on outcomes. That was definitely something we considered.
Okay. It's probably a good time to talk about that now, actually, to wrap up the contextual bit. So, tell us a little bit more about that framework, Nathan, what its purpose is, and what it would mean to, so is that not just to commissioners, but to people actually heavily involved in delivering supported self management.
Yeah. Well, this is an idea that came from Joel McGoldrick, and her health and wellbeing coach colleagues, who work in the Black Country, um, and they came to us and asked for some support with measuring their impact. They tried a couple of different approaches before, weren't necessarily didn't feel like they'd necessarily solved the problem, as it were. So,
Yeah.
um, you know, there's a need to continue that conversation. And that kind of grew to be something that brought together health and wellbeing coaches from around the country to talk about, um, you know, what are the key outcomes that health and wellbeing coaching aims to impact. Um, what are the other factors that could potentially influence those outcomes? And how do we build a framework that allows us to measure those things so that then we can come to some kind of um, relatively unbiased estimate of the effect of the coaching itself. Um, so we've been working on that for nearly a couple of years now. We're at the stage now where we have a framework that is being tested in PCNs. And yeah, we're looking forward to seeing what comes out of that. And yeah, whether it can help us get a more defensible estimate of that causal effect of health and wellbeing coaching.
Okay. Cool. I'm going to pick up on that at the end of the podcast. Actually, that'll be a nice segue. But if we'll hold that for now, I suppose the second phase now of the podcast is exploring challenges. I suppose from my perspective, and I won't go into too much detail, or I won't ask you to go into too much detail because it's more about challenges and actually focusing on things that we've got some element of control over. My biggest bugbear, which I won't want us to go into too much detail, is around salience. But I think there's on balance, I think too much attention played for obvious reasons on constitutional performance on in the NHS, where we are challenged by national government to look at things constitutionally, and then therefore we look at them through our contracts, and they tend to be on indicators around how fast we do something. So they're all time orientated. The medium term planning framework, many of the indicators are all based on how fast we provide access to care to the public, which does, in my opinion, can really miss out on the opportunities around, well, okay, well, what about secondary outcomes in terms of, right, do people feel better in light of treatment? Were they able to get a job? Um, did they feel like their levels of knowledge, skills, and confidence have improved if they were to be endured with something similar again? Um, and yeah, I suppose I don't want us to go into too much because I know there's a lot we can't control politically. I wish we could, but we can't. Um, but what I wanted to do, I suppose, is to dig a bit deeper into I suppose, the nuances around things that are within our control, that are challenging, but are, I suppose, with a little bit of work and a bit more understanding from those involved in it. So, what are your thoughts, Nathan, around challenges, especially in respect of measurement supported self-management, and how we might start to try and overcome those?
Hmm. Um, well, thinking about what you've just said, and some of the national drivers around these sorts of things, um, I suppose my feeling would be that there are lots of things that are easier to measure than the outcomes associated with supported self-management. Um, and when you are trying to evaluate a service or figure out what return you're getting on investment, um, you know, it's very easy to prioritize those things that you can easily measure.
Yeah,
Um, and deprioritize those things that you can't measure very well, right? So there is something about um, a line of thinking that says, well, we fund it because we can measure it. So we know what we're getting back there and for our money. And that gives people maybe a bit more confidence to invest. Um, even if um, the outcomes that you're seeing are not necessarily the best outcomes or the ones that are most aligned with your strategy, perhaps. So I think supported self-management falls into the hard bucket for a lot of reasons. I think um, one is that when it comes to supported self-management, everybody is different, right? So it's not like you're just giving the same pill to everybody, or doing the same surgery. Um, it's everybody is different in that sense, and every intervention is different. Um, and also, what we tend to be dealing with is kind of like the nexus of lots of different issues, rather than it being, you're being treated for cancer, or you're being treated for diabetes, or you're taking like a condition at a time.
yeah,
With supported self-management, you have all these factors like, well, it could be something to do with somebody's physical health, but also you've got, mental health, you've got social factors, environmental factors, their relationships, their work situation, their housing, all of this stuff. And not all of it is going to be within the gift of somebody delivering supported self-management to influence directly.
yeah,
So I think those two things, like first of all, the fact that every intervention is different, and second of all, just the complexity of the problem that we're trying to address makes supported self-management difficult to measure. Um, and I think a lot of the standard tools that people use for measuring the impact of medical interventions are not necessarily appropriate or um, practicable when it comes to measuring the impact of supported self-management.
Okay. So I think we've highlighted that with constitute. I mean, I'm not going to label all of it because there are probably constitutional performance is quite vast, and there might be some areas where constitutional performance does invite the opportunity for us to be able to understand outcomes from a more personalized perspective. So I don't want to I don't want to make a judgment blanket on it. So forgive me if that has us, but I think my concern would be is that there might be areas where with the more constitutional performance where we're mandated to understand a success or failure, it might the outcome being shown and reported might not actually represent the underlying problem that that patient felt was being addressed because there are
Mm.
like you've said there's some underlying fingers underplaying it. Yeah, that I think that's always going to be the issue. Like I don't a classic example is I don't think we should measure success and failure of our A&E services over whether or not they've got a 4 hour success in a 4 hour wait. I just think that's a really narrow-minded, restrictive way of doing it. There are so many other areas we could do it, but yeah, boundaries. There's only things that we can control, but I just think it's important to acknowledge that. Um, so if we feel that people might have a propensity to favour an outcome that matters to them, and not just people or organisations, how does the use of I think when we spoke about the planning it the podcast, we spoke about the importance of making sure we have a conversation about the design of the study itself. So, do you want to talk us through a little bit more about what we mean by that, Nathan?
Yeah, yeah. Well, I've hinted already, like I've mentioned that a lot of the outcomes we're interested in are affected by lots of different things. If you're talking about health and well-being in general, that's shaped by so many different factors. Um, so if our aim is to um, is to have some sort of effect on, say, health and well-being, um, then we do need to take into account other factors that might also um, result in a change. And a key kind of danger whenever you're doing this sort of measurement is what's called confounding, where you get some factor that influences both the likelihood that somebody comes forward for the intervention, so puts themselves forward for coaching or the social prescribing or whatever, and the outcome that you're interested in, right? So if people who are more likely to see an improvement in their health and well-being
Yeah,
are also more likely to participate in social prescribing, for example, then you don't know how much of the effect is due to the social prescribing and how much of it is
yeah,
due to this other factor that is confounding the relationship
yeah,
between social prescribing and your outcome. Um, and a lot of the studies we see of social prescribing, health and well-being coaching, and care coordination, similar services like that, um, the way in that they're designed is that they only measure the outcomes, and they're not measuring all this other stuff that could potentially be affecting the outcomes and
mm,
potentially introducing confounding, right? So we need a study design that can control for confounding, um, but at the same time, it needs to be flexible enough to accommodate the different the different shapes of the things that we're doing, the actual interventions
Yeah.
themselves, right?
Okay.
Yeah, so the go-to is always a randomized controlled trial. Um, Randomized controlled trials, you have a treatment group and a control group. And the idea is that the treatment group and the control group are basically the same for in every relevant respect, apart from the fact that one gets the treatment and one doesn't, right? Um, and the kind of magic that makes that happen is randomization. So if you're uh, randomly assigning people to either the treatment group or the control group, then the idea is that you end up with two groups that have roughly similar numbers of, say, people from different ethnic backgrounds or people of different ages, or whatever that those potential confounders might be. Um, the two groups end up the same due to randomization. And then you can compare the difference between the two groups, you see, to get the effect of the intervention. Um, and that works really well if you can set up a randomized controlled trial. And if it exists as a possibility, I'd definitely say try it. But there are issues with it as well. They can be very expensive to run. You need a large sample size. There are ethical concerns um, with withholding treatment from the control group, for example. Um, there are concerns around, well, okay, you're randomizing people to these two groups. So what does that do to people's agency in that sort of situation where the choice to either participate in the treatment or not is essentially taken away from them by this randomization? So there are questions around how you do that in a supported self-management context. But if we could overcome those challenges, that would be ideal. But also we need alternatives that can deal with the risk of confounding, but don't necessarily suffer from some of those issues around
Okay.
the ethics and the practical challenges.
Okay, cool. So I think when we were planning, you spoke about the importance of striking the balance between the framework that reflects the outcome versus the one that works across different types of interventions. Do you
Yeah,
yeah, is that do you want to kind of just clarify what we mean by that? That's because I
sure,
mean
yeah,
especially for me because I'm not a research expert
yeah.
at all. So yeah, I think I'd appreciate it, and I think others would appreciate what we mean by that.
Yeah. So we with the health and wellbeing coaches project, um, we we didn't do a randomized control trial. We've done something different, and we've built this framework that should allow us to control for confounding without having to do with a randomization. Um, so and we designed the framework to be as generic as possible, right? So the way that what that means in health and well-being coaching terms is that you should be able to use it um, for any kind of health and well-being coaching in any kind of setting. So regardless of what condition you're coaching for, regardless of whether it's in primary care or in another setting, um, it should be flexible enough to accommodate the kind of coaching that you're trying to do. And that meant focusing on outcomes that were um, applicable to every coaching situation. So for health and wellbeing coaching, we're talking about, increased self-efficacy, increased sense of control over your own health and well-being, having that sense that you can move forward with your health and well-being. And then in terms of the health and well-being outcomes themselves, looking at general improvements, do you feel better on a day-to-day basis, right? have you seen any change in the symptoms and the measurements that matter to you? And the idea is that, if you are coaching for a specific condition, so say, for example, weight management or something like that, and there are clinical biomarkers associated with that condition that you're interested in, then you can very easily add them to the framework. And that you would then get the benefit of taking that measurement within this context that allows you to control for confounding.
Okay.
So that
Yeah.
was the thinking behind trying to make a framework that was generic and flexible in that sense. Is that what you're
Yeah.
asking about?
Yeah, that makes sense. I think that's also gearing people towards thinking, as opposed to when they've got this intervention and they've got a tool to measure its effectiveness, it's not just thinking, oh, I'm assured now that I can measure its effectiveness because I use this type of tool. The tool itself really, it's not that it doesn't matter. It's more about, I think what we're getting at is more about the design of the study. So think about evaluations really, really early doors. Don't think about the value of what you're doing just on the tool you're using, like whether it be a well-being score like WebWebs. That's
Mm,
really, it is important. I'm not knocking that, but it's more about thinking upfront, really, really early doors. If I was going to explore a study to see how effective this service is,
mhm.
beyond just the tool to measure success or failure, um, it's this type of conversation that we're trying to encourage people to think about, aren't we? When they're
Yeah,
commissioning it or they're providing it, that's what we're getting them to try and think about.
yeah. I think if you're just kind of like measuring something at the start, then
Mm.
doing your intervention, measuring it again at the end, um, then to some degree it doesn't really matter what tool you're using. You're still going to get a result that is biased in some to some extent by confounding, unless you're really lucky and all the potential confounding factors that impact your outcome are stable over time. Um, then in that case you might be all right. But when we're talking about health and well-being, we know that that's not the case, right?
Yeah,
There's so many things that can change over the course of an intervention that then can impact outcomes, and also people's ability and willingness to engage with the intervention.
yeah,
Um, so so yeah, I would say, whatever tool you're using,
yeah,
make sure you're using it within a study design that allows you to control for those confounding factors, because that's the only way that you're going to be able to get a result you can be confident in, I think.
okay. Um, I suppose we didn't talk about this in the planning session, but if I was just if I was like a commissioner, or if say for example if I was just a provider, other than just people like yourself, Nathan, who might someone talk to about design of a study? Who would be like kind of well qualified for that? So because I mean I imagine some people might be completely new to it and they might not know who to talk to about that.
Sure, yeah. I think if you are working with uh, a higher education institution, um, researchers from a university, and they are they have a statistical background. They will be aware of these issues, and they will be have at least some awareness of potential solutions. So academic partnerships are definitely a route to go down. Um, other options, there is quite a lot of guidance out there on the internet that you can find, but there's two that I would highlight, maybe three actually. One's not come out yet. Um, so the HM Treasury have published what gets known colloquially as the Magenta book. And it's called that so frequently that I can't actually remember its actual title. But I think if you do a search for HM
Yeah.
Treasury Magenta book,
Okay.
it's basically it's a guide to evaluating complex projects.
Yeah.
So it's kind of like the Treasury's official guidance for how you measure the return on investment and for complex interventions. And that's got lots of useful prompts for thinking in. So I would recommend that. The second thing that this is one that isn't out yet, but a colleague who works at NHS England is just about to produce a guidance document, and it's on a topic called causal inference, which is the kind of like broad family of approaches for basically inferring causal effects from
Yeah.
studies. So the approach that we've taken with the health and wellbeing coaches framework is an example of causal inference. It's one way of doing it. So he's about to publish a kind of guidebook to doing causal inference in NHS service evaluation. And there's going to be lots of stuff in there that is relevant as well to practices outside the NHS as well. So keep an eye out for that. I'm sure we can put links in the
Yeah, we could
notes
put a
or
link in
something
there.
like that. Yeah.
Yeah, yeah, yeah.
And the third thing I'd recommend is a book by a chap called Julia Pearl,
Yeah.
writing with Dana McKenzie. It's called The Book of Why. Um,
Yeah.
and there he writes very eloquently, or they write very eloquently, about why it's important to consider things like confounding when you're trying to understand causal effects. And he's got loads of great examples from history about how people have or have not successfully managed confounding in their studies and how that led them to the right answer or the wrong answer, as it may be. So,
Awesome.
so yeah, I would definitely recommend starting with those three things.
Cool. Okay. So I think we the main reason why we did the video was obviously to help nudge people or that them maybe if they were trying to unpick a problem around evaluating their interventions or if they were involved in leading commissioning it'd be to help, I suppose, nudge them to help think differently. If there anything else, if we're thinking about it in the context of getting people to carry on the conversation, is there anything else that we've not covered that you think might help that or might inspire people?
Um, I guess really it's just a plea to keep on having these discussions and keep on upping our game in terms of the quality of the evidence, right? So there is evidence out there that is a really useful starting point for understanding the effects of supported self-management. I keep saying that wrong.
So
But yeah, there's some good work that has already been done. A lot of it has come out even this year. There's stuff being published, and but I think we need to do more. And what brought that home to me really was I was at a conference not long ago, and there's a chap from NICE there, so the National Institute of Clinical Excellence. And these guys produce among many other things, they also produce the clinical guidance that all clinical professionals are supposed to follow in the UK when they're deciding about, what treatments to give people and things like that. And they said that when they're creating this clinical guidance or when they're updating it,
mm,
um, the only studies they actually look at are from randomized controlled trials.
Right.
And that's not because they think that you can't learn anything interesting from any other kind of study design. It was really more about capacity, right? So they didn't have time to consider every single thing that was out there. So they used randomized controlled trials as a sort of filter to get them, what they thought would be the most relevant evidence for consideration, right?
Yeah.
But that really highlighted to me that, if you're not seen to be meeting a certain standard in terms of the quality of your evidence, how you're controlling for confounding, then you're not even getting anywhere close to influencing the clinical conversation
Yeah.
around, what happens in healthcare settings. Um,
Yeah.
and that made me think, oh yeah, we do need to be thinking more about this, because the bar is high, particularly from a clinical perspective, and we need clinicians on board if we're going to be able to um, make this happen, I think.
Yeah, I agree, and I think it's a lovely way of wrapping up podcast today, because I think what it speaks to is that a lot of the um a lot of the, for want of a better word, the prestige around measuring impact of interventions, I suppose, not just well, a lot of it's in NHS services. Some from a clinical perspective, are of the ones that you've described, where, yeah, I mean, we've got, if NICE are looking at it, where they will look at developing a lot of their standards. In fact, you said all of their standards using randomized control trials, for their clinical standards. What it what it does is, I suppose, it kind of, for me, risks a whole body of evidence not being considered. And I think it would be good if we carried on the conversation, and if we challenged um people who are looking to explore, to consider different bodies of evidence, to maybe be to take a more progressive approach in how that they measure success and failure, to consider different bodies of evidence that I know might not have the prestige, granted, but I still think that there's value in that, in at least exploring that, because success and measure can be explored in so many different ways. It's very, very subjective. And the
Yeah,
more you peel the onion, I think the more you find out actually something that might be labeled as a success, actually, it might not be. It might not look like that if you keep peeling the onion, because it's very subjective. But no, really appreciate your time, Nathan. Thanks for coming along to the second podcast. We've got a whole list of other podcasts to look at next year, hopefully, if we've got capacity. But in the meantime, we'll make sure we've got the resources that you spoke to around causal invariance, the book of why, which I'm going to read into definitely, and the Magenta book as well. We'll find out the exact description of that, the official description, and put that in the description of the YouTube video. But in the meantime, thanks very much, Nathan, and all the best to everyone. And have a good Christmas as well, obviously.
thank you very much, Tez. Thank you for having me on, and
Thank you.
yeah, same to you.
All the best. All the best. Take care.